Good afternoon, everyone, and welcome to this guest lecture on updates in spondyloarthritis. And I have this privilege and pleasure to welcome our distinguished guest speaker here today, Dr. Abhijeet Danve. Dr. Danve is the Associate Professor of Medicine at Yale University, New Haven, Connecticut. He completed medical school and internal medicine residency from St. G.S. Medical College and KEM Hospital, Mumbai. And after that, he did his clinical rheumatology fellowship at Oregon Health and Science University, Portland, and research fellowship at University of Nebraska Medical Center, Omaha. He is the recipient of several distinguished awards, like the Marshall J. Schiff Memorial Research Award, the Distinguished Fellow Award given by the ACR, and Jane Ruckel Early Career Award by Spondylitis Association of America. Dr. Danve has a particular interest in patient care and research in the field of spondyloarthritis. Currently, he is the director and he is the founding director of Yale Spondyloarthritis Program, which provides comprehensive multidisciplinary care to the patients with spondyloarthritis. His areas of research are on early identification and diagnosis of axial spondyloarthritis. He is a member of the Spartan group, that is Spondyloarthritis and Treatment Network, the ASAS group, Axial Spondyloarthritis International Society, and the GRAPPA group, that is Group for Research and Assessment for Psoriatic Arthritis. On a personal note, he is a very good friend of mine, and we have family connections going back almost 25 years. So without further ado, I want to welcome Dr. Abhijeet, and I would like the HOD of Department of Clinical Immunology and Rheumatology to felicitate him. Stage is yours, Abhijeet.
Thanks a lot, Varsha, for that kind introduction. Thank you, Dr. Krishna, for providing me this opportunity. It's a privilege and honor to be here and share some of the work that we are doing, as well as teach you some about axial spondyloarthritis and learn along the side. Okay. So these are my disclosures. Today's objectives are to learn about changing nomenclature, classification, and clinical features of spondyloarthritis, which is a group. Identify ways for timely diagnosis of axial spondyloarthritis, which is an important unmet need in the field, as I will allude to. Summarize the non-pharmacological as well as pharmacological treatment options for axial spondyloarthritis. And appraise the available evidence on strategy trials involving tapering and discontinuing the biological DMARDs for axial spondyloarthritis. This comes from a patient who's doing really well, always asks us, do I have to take this medicine? Do I have to continue it? Can I stop? And we will go through the data about it. As I'm assuming we are all clinicians mainly, and I am clinician at heart. I won't be able to do only research in a lab. I like to see patients, and that's how our education has been. So we will start with a case. We have a 44-year-old woman with chronic low back pain for 6 to 8 years. The back pain is worse with prolonged rest. It improves with exercise and activity. Patient has to wake up in the middle of the night because of the back pain. She tells you that NSAIDs provide significant relief, and she needs to visit her podiatrist or foot doctor once in a while for recurrent plantar fasciitis. She has normal range of movements at the L spine, mild tenderness at insertion of the plantar fascia at calcaneus. Otherwise, the joint examination is normal. The blood tests are normal, ESR, show normal ESR and CRP. The clinician is thinking because of the back pain and plantar fasciitis about condition like spondyloarthritis. So HLA-B27 was ordered and that came positive. An X-ray of the pelvis AP view, X-ray of the pelvis AP view, that's the test that you ordered to look for sacroiliitis. That was done and that was reported to be completely normal, as you see here. What would you do in this case? MRI. So as our fellow said, the physician still had high suspicion of spondyloarthritis, and an MRI, a patient was referred to rheumatologist who did the MRI. And as you can see here on the T2 weighted images, you can see a lot of bone marrow edema on both sides of both SI joints. So it is definite MRI sacroiliitis. So now question is, this patient X-ray was normal, MRI was abnormal. She has typical symptoms. What would we call her as having? Like, what's the diagnosis? Non-radiographic axial spondyloarthritis, right? So this was an important development in the field in around 2009, 2010, because before that we used to call patient undifferentiated spondyloarthritis or ankylosing spondylitis, but mainly everybody wanted to see an abnormal X-ray to come to a diagnosis. And it takes like 8 to 10 years for X-ray to become abnormal. So you don't want to keep a patient untreated for several years because there are implications like fusion and loss of work productivity, etc. So as we all, I think, know, axial spondyloarthritis is the new name for ankylosing spondylitis. It's a broader spectrum. It includes both the non-radiographic stage as well as the radiographic stage, which is ankylosing spondylitis. So this is immune-mediated chronic inflammatory disease affecting the axial and peripheral skeleton as well as extra-articular organs like skin, gut, eyes. Mainly affects young individuals in their third and fourth decade. So when they're most productive in their careers and life, and frequently leads to significant pain, loss of function, work disability, impaired quality of life. Many of these things are subtle. So patients just put up with, they change the lifestyle around it. They will not buy shoes with the shoelace. They'll just buy something simple. They change their habits around the symptoms, but the symptoms are not as debilitating as they would be for maybe rheumatoid arthritis, where they have to seek care. So several patients don't seek care until late just because the symptoms are gradually progressing and they are like intermittent, sometimes like plantar fasciitis or anterior chest wall pain maybe. So this condition is quite heterogeneous, as we know, and the progression is also not linear. Not every patient with non-radiographic axial spondyloarthritis is going to develop ankylosing spondylitis eventually. Therefore the responsibility is upon us clinicians to really pick these patients who may have this condition, diagnose them, start them on treatment early so we can improve the symptoms, quality of life, but also prevent long-term comorbidities and complications. So why we should care about this condition is not every patient's back pain is mechanical. There may be inflammatory back pain as well as from spondyloarthritis conditions, any of them. This is much more common than we think, frequently missed by internists as well as rheumatologists. I'll tell you some snippets about how this is missed in rheumatology offices too. And as any other inflammatory condition, say lupus or rheumatoid arthritis, inflammatory conditions are associated with comorbid conditions like hypertension, risk of heart disease, stroke, etc. And more so now, in the last 1 decade or more, we have great treatment options. We don't have these patients coming to us, but we do have excellent treatment options to improve their quality of life and make difference in their lives. That's why we should care about this. So what do you think? How common is axial spondyloarthritis? I have data from United States and maybe Europe. I don't have as much data from Indian studies as such, but any guesses? What do you think? Out of people walking on the street, 1 in 200 individuals have ankylosing spondylitis in United States. Not axial spondyloarthritis, not the heterogeneous condition which they may or may not have. Non-radiographic axial spondyloarthritis is slightly controversial because sometimes you do not have a definitive imaging or objective finding and you have to make the decision based on the clinical judgment. So it's much more common than what we think. And there is a huge spectrum. So for the clinical relevance and for the treatment purpose also, we like to think about this condition as axial group and peripheral group. Among the axial spondyloarthritis group, you have early stage, that's non-radiographic axial spondyloarthritis, late stage or radiographics or synonymous with ankylosing spondylitis. That's a smaller group in the axial spondyloarthritis group. On the right side, you will see peripheral spondyloarthritis. There are 3 main conditions: psoriatic arthritis, reactive arthritis, and arthritis of inflammatory bowel disease, Crohn's or ulcerative colitis. There's small proportion which do not really satisfy this, and we call them undifferentiated spondyloarthritis. There is significant overlap among this. So About 30% patients with psoriatic arthritis can get involvement of the axial skeleton. So you call them axial psoriatic arthritis. And about 20 to 40% patients with ankylosing spondylitis can develop peripheral inflammatory arthritis. So there is significant overlap. But when you think about the treatments, some of the treatments like interleukin-23 inhibitors do not work in patients who have axial inflammatory arthritis. So this classification is quite clinically relevant when you are seeing patients day to day. Typical clinical features of axial spondyloarthritis or spondyloarthritis as a group, you can think about them as musculoskeletal manifestations and non-musculoskeletal manifestations. Among the MSK features, you have inflammatory back pain, that's the most common, peripheral inflammatory arthritis, dactylitis, enthesitis, which we think is the pathognomonic or the basic lesion pathologically is enthesitis. So this is like a polyenthesitis problem. And anterior chest wall pain, but which is nothing but enthesitis. Among the non-MSK features, you have uveitis, which is the most common extraarticular manifestation, followed by inflammatory bowel disease and psoriasis. In addition to this, patients can rarely have other symptoms too, but these are like, and they're constitutional: fatigue, low-grade fevers once in a while, etc. The spondyloarthritis conditions are axial involvement than peripheral involvement. There tends to be familial aggregation and osteoproliferation as compared to osteodestruction that you see in rheumatoid arthritis, sometimes in psoriatic arthritis. You don't see only erosions in ankylosing spondylitis. That's followed by new bone formation and sometimes syndesmophyte formation. When I was in medical school, we used to call it seronegative spondyloarthropathy. And this seronegative came from every patient would get rheumatoid factor, and that was negative. That's why seronegative. And we used to call it spondyloarthropathy, which is kind of a too broad a terminology. So we like to call it spondyloarthritis, like it denotes inflammation. Inflammatory back pain is the cardinal symptom, especially in axial spondyloarthritis. 90% or more patients have inflammatory back pain at the time of diagnosis. By definition, starts before age of 45, lasts for more than 3 months. Prevalence of low back pain in general population in United States is 20%. So 1 in 5 people walking on the street have chronic back pain. And only 5% of them have axial spondyloarthritis or ankylosing spondylitis. And it's a challenge how you pick up these patients because as you know, there is no definitive blood test at this time. And you cannot do MRI of the sacroiliac joints for the whole population of back pain. So you need a filter. You need improved awareness education among the referring doctors. And the second thing is you need to use some kind of a filter, because as rheumatologist, if you start seeing back pain patient, then you don't have time to give to our patients with lupus or rheumatoid arthritis or some other rare autoimmune inflammatory conditions. Anyways, inflammatory back pain is very sensitive feature, like 85 to 90% even, but the specificity can be as low as 30%. So in large cohort of patients with back pain, up to 30% patients without axial spondyloarthritis may fulfill the definition of inflammatory back pain. Characteristics, I think some of them we already included. Insidious onset, morning stiffness more than 30 minutes, starts before age of 45, lasts for more than 3 months, improves with exercise, does not improve with the rest, can wake up the patient in the middle of their sleep, especially in the second half of the night, with improvement on arising. Some patients get out of the bed, stretch, and then go back to sleep. Alternating buttock pain is quite specific, but not as sensitive. And there are several definitions for inflammatory back pain and several criteria, but they are supposed to be used for clinical research purposes. As rheumatology is still art of medicine, we use a lot of art of medicine or pattern recognition. So more important is asking patients open-ended questions, let them tell you, rather than asking, do you wake up in the night because of the back pain? So tell me more about your back pain, and let them go on. That's where you get the information. So these are several criteria. The most recent is ASAS criteria. And if you want to remember, there is a mnemonic called IPAIN, IPAIN. So improves with exercise, patients age less than 45, insidious onset, pain at night, and no improvement with the rest. How do you differentiate between inflammatory back pain and mechanical back pain? Is the onset of inflammatory back pain in majority. I do have some patients who get flare-ups of acute debilitating sacroiliitis where they cannot get out of the bed, but more or less the inflammatory back pain is gradual. Mechanical back pain can be variable. Morning stiffness is not as prolonged in the mechanical back pain patients. The maximum stiffness or pain is early morning and second half of the night for patients with inflammatory back pain. Improves with exercise, as we said. Duration tends to be chronic. Age is less than 45. In the mechanical back pain, it can be variable. And importantly, the inflammatory back pain responds very well to NSAIDs. And some patients do not come to the doctors because they keep on taking NSAIDs. They don't feel the need. I do have a colonel in the United States military who was taking Advil. We call it Advil. So ibuprofen for years and years for his chest wall pain. And then he developed Crohn's disease. So his GI doctors told him to stop NSAIDs. That's when he developed uveitis, he developed chest wall pain. He came to us. And that's when I found him to have sacroiliitis. So he was popping NSAIDs for years and years before the disease was diagnosed. So although we symptom burden using different patient-reported outcomes or functional indices or pain level or fatigue level, you will see that non-radiographic disease as well as early AS, which is less than 5 years, late AS, their symptom burden as measured by the disease activity measures, pain level, functional indices are very similar. Metrology, which is BASME, I'm assuming that you guys know these mnemonics. If you don't interrupt me, I'll be able to tell you. So metrology index is the only one, as one could think, in patients with ankylosing spondylitis who have syndesmophytes and limited range of movements, their metrology indices would be worse. But in early AS or in patients with non-radiographic axial spondyloarthritis, your metrology indices may be as normal as the general population. So inflammatory back pain is the cardinal symptom of patients with axial spondyloarthritis. The second was in his peripheral inflammatory arthritis. It's usually acute, it's intermittent, it's asymmetrical oligoarthritis, so 4 and less joints, and it somehow favors the joints of lower extremities, knee, ankle, much more commonly than the elbow and wrists, typically large joints rather than the small joints. About 30 to 40% patients with axial spondyloarthritis will develop peripheral inflammatory arthritis, but when you see them, they may not have anything going on. So it's because it's intermittent. It's important to elicit the history from them. Enthesis is the site of insertion of ligaments, tendon, and capsule to the bone. It's early and relatively specific feature of spondyloarthritis. You don't see as much you don't see enthesitis in lupus arthritis. You do not see enthesitis in rheumatoid arthritis patients. Enthesitis is quite typical or specific for the group spondyloarthritis. And immunopathogenically, it is a polyenthesitis condition as well as synovitis, whereas rheumatoid arthritis is typically synovitis. Lupus is typically synovitis. Here it's osteitis and enthesitis that is controlling the inflammatory pathway. That is actually dictating the inflammatory pathways. Common sites for enthesitis is Achilles tendon insertion, plantar fascia, belt area, lateral epicondyle, that's tennis elbow. So when patients say hip pain, it is very interesting. It can be so many things. People, like when they say hip, the kambar, right? That's what they would say, kambar dukte. So that it could be so many things. It can be spinal condition, it can be sacroiliac joints, it can be the hip joint. Many times it's trochanteric bursitis, and sometimes it's enthesitis of the iliac crest area. So it's very important to elicit the correct history when somebody says, "Maji kambar dukte" or hip pain. I have identified several patients with psoriatic arthritis. They had psoriasis, some aches and pains, but typically the belt line pain is a typical early feature of patients with psoriatic arthritis. There you see in the picture on the right heel, the Achilles tendon is swollen. There's fusiform swelling at the right one. And on the MRI, you see a lot of inflammation, the T2-weighted hyperintense signals there. Enthesitis, as in inflammatory back pain, there are several indices that are supposed to be used for clinical research purposes. They include Maastricht, the Spark, the Leeds, but these are not to be used for the, like you can use it for clinical practice, but they don't help you as much, or you don't have enough time during a busy clinic to record the data. But if you can, that's great. But common sites where you are going to examine for enthesitis is anterior chest wall, the mandibulosternal joint, the lower costal cartilages, the iliac crest, the trochanteric area, the ischial tubercles, then around the elbow, the knee, suprapatellar as well as infrapatellar tendon, Achilles tendon, plantar fascia insertion. And you can clinically see, and if you do have enough time, Leeds enthesitis index is the easiest to record. Dactylitis is another characteristic feature of spondyloarthritis group, more so in psoriatic arthritis and reactive arthritis. Sometimes you can see that in ankylosing spondylitis, and it results from diffuse swelling of the flexor tendons, the tendon sheath, and adjacent soft tissue, and it can also involve the joints. There are several other conditions that can cause dactylitis. The most common is trauma. So first thing that we want to rule out is trauma, but patients with TB, so Ponson's disease, I think you guys may see more than us. We have only been reading about it. And I had seen Ponson's when I was studying, doing my MD medicine in Mumbai. Sarcoidosis can cause dactylitis, sickle cell disease, and tophaceous gout. These are some conditions that can cause dactylitis. In the right clinical context, when somebody does have psoriasis or family history of psoriasis, inflammatory back pain, in elevated inflammation markers, if you have dactylitis, then you got it. I do have a lady that works at our university. She is in cleaning services, has disfigured toenails, fingernails, dactylitic looking toes, and couple of fingers, very high rheumatoid factor, very high CCP. CCP titer more than 250, rheumatoid factor titer like more than 200. And so I diagnosed her as psoriatic arthritis, not rheumatoid arthritis. And she did not respond at all to the TNF inhibitors, to the interleukin 17 inhibitor, ixekizumab, that's the TALTS, I don't know if it's available here. She improved within 3 months. Her toenails and fingernails are getting better. The dactylitis went away. So not every patient with positive CCP is rheumatoid arthritis. And the diagnosis clincher was the dactylitis. So that's how it can be helpful. Uveitis is the most common extra-articular manifestation of axial spondyloarthritis. And this is function of the disease duration. When you see the patient at onset, they may not have uveitis episode by now, but when you see them over years, the prevalence goes up and up. So among the patient with acute anterior uveitis, 50% of them have spondyloarthritis condition. And 50% instances are associated with positive HLA-B27. I had privilege to train under Dr. Jim Rosenbaum. He's considered a world expert he's a rheumatologist, ophthalmologist. And he has uveitis fellowship, 1-year uveitis fellowship that a rheumatologist can do or an ophthalmologist do. And he has his fellows now practicing all over United States, and got to learn about a lot of inflammatory eye condition then. And how it was helpful is just a couple of months ago, I diagnosed a patient with TINU. Heard about TINU? TINU. Yeah. Uveitis, right? It only comes as MCQ in one of the entrance exams, but this is what I saw. So uveitis in spondyloarthritis typically is unilateral, anterior, acute onset, self-limited, and recurrent. It seldom leads to loss of vision unless you treat them, unless you do not treat them during the acute period and they develop synechia and further complications like cataracts. Typically unilateral, but in patients with psoriatic arthritis, you can find bilateral uveitis, and it can be sometimes posterior. Patients with psoriatic arthritis can also develop uveitis as well as IVID, but not in the same frequency. It's much more common in ankylosing spondylitis or axial spondyloarthritis group. Psoriasis in general population is, anyways, it's common. About 3 to 4% of the population has psoriasis, frequently involves skin and nails. Most commonly plaque psoriasis, and among the patients with axial spondyloarthritis, about 10% have psoriasis. And this comes handy when you see a patient with inflammatory looking back pain. If you examine their scalp, hairline, the gluteal fold, the fingernails, the belly button, these are the sites where you find occult psoriasis. And presence of psoriasis in the right patient increases the probability of axial spondyloarthritis. Inflammatory bowel disease, if you think about axial spondyloarthritis or psoriatic arthritis, inflammatory bowel disease, reactive arthritis, more than autoimmune, these are inflammatory conditions. And this comes from exposure to environmental factors like altered microbiome, smoking. So microbiome plays a major role in shaping our immune system, as we know. Altered microbiome is way common in spondyloarthritis group as compared to lupus or rheumatoid arthritis patients. And if you do random blind colonoscopic biopsies of consecutive patients with ankylosing spondylitis or axial spondyloarthritis, 50 to 60% of them will have abnormal pathological findings on the colonoscopic biopsies. About 6 to 8% of them have clinically manifest inflammatory bowel disease, Crohn's disease, or ulcerative colitis. Similarly, about 20% of the patients with IBD can have spondyloarthritis features, including silent sacroiliitis. So this has been a repeated pattern. When you see patients with ankylosing spondylitis at the diagnosis, the prevalence of uveitis, psoriasis, IBD may not be as great, but as the disease duration goes up, the prevalence of the extraarticular manifestations go up. And this has been shown in multiple studies. This is one of the conditions which is strongly associated with genetic predisposition, typically HLA-B27, but at the same time, it's not a confirmatory test because prevalence of HLA-B27 in general population in white Americans is 6 to 9%. In Indians in India, it is about 6%. It is higher in North Americans than in North Indians than in South Indians. And while 90 to 95% with AS have positive B27, about 70 to 85% patients with non-radiographic axial SPA have positive HLA-B27. Among the people with positive HLA-B27, only 5% will develop ankylosing spondylitis. And if you want to stretch your imagination, maybe another 3-4% having psoriatic arthritis or IBD. So 90% people with positive HLA-B27 will never develop a spondyloarthritic condition. That's why this is not a definitive test. And in our health culture, like healthcare, sometimes people get hung up on an abnormal test and then want to self-diagnose, get treated with biologics, etc. And this can lead to chain reaction. So we are very careful before ordering HLA-B27. Unless we have high suspicion, we do not typically order HLA-B27. The 20% of the patients with positive HLA-B27 positive ankylosing spondylitis, who also have positive HLA-B27, will eventually develop some kind of spondyloarthritis. So that way, when you see an adult patient with ankylosing spondylitis, it will be important to inquire about their family members because about 20% of them are going to develop one of these spondylitis conditions. Although we harp so much on HLA-B27, it explains only 40% of the overall risk of spondyloarthritis. So this is a polygenic condition as compared to DADA, deficiency of adenosine deaminase, that Dr. Aman Sharma, yeah, he's working on this, and he's well known for his work on DADA2, where there is a monogenic disease. You give them TNF inhibitors, they get better. Axial spondyloarthritis is a heterogeneous condition, polygenic disease. That's why you see the penetration is different, the intensity and severity of the symptoms and manifestations, the involvement of extraarticular that's all different in patients. Now, frequency of B27 in different types of spondyloarthritis. Wherever there is spondylitis, ankylosing spondylitis, psoriatic spondylitis, or enteropathic spondylitis, they will have more prevalence of B27. So ankylosing spondylitis is 80 to 90%. So this number keeps on changing. This is not absolute. More or less 85 to 95%. That's what you will find in ankylosing spondylitis. When you see the non-radiographics, it is typically lower. So the B27 is a risk factor for severe disease, in other words. In psoriatic spondylitis, about 50 to 60%. In enteropathic spondylitis, it's about 70%. Whenever there is pure peripheral psoriatic arthritis, you're not going to find as much positive HLA-B27 there. So what are the differences between patients? So that's another thing. There exists a population of ankylosing spondylitis, like fused SI joints patients whose HLA-B27 is negative. So a negative HLA-B27 does not rule out ankylosing spondylitis or psoriatic arthritis for that matter. And that's why it's important to look at the whole clinical picture rather than one blood test or two, or one abnormal MRI or X-ray, because there are inherent challenges in reading X-ray. There are inherent challenges in reading MRI because MRI is too sensitive a test. Nonetheless, the differences between positive HLA-B27 positive patients with axial spondyloarthritis versus HLA-B27 negative patients with XPA. There are more men in B27 positive. Age of onset is younger. The age of diagnosis is earlier because then we have something to bank on. The delay in diagnosis is not as much. Familial occurrence is more. Uveitis is more common. Psoriasis and IBD is less common. I experienced this I will tell you about a research study that we did, and we did find several patients with axial spondyloarthritis who had negative HLA-B27, but had psoriasis and IBD or family history of psoriasis and IBD more often. And B27 patients are at higher risk of radiographic damage, as well as a response to the biologics. And the reason for that is after the introduction of ASA's classification criteria, people are using the checkbox method of diagnosing them as non-radiographics. And many patients with fibromyalgia, mechanical back pain gets diagnosed as non-radiographic axial spondyloarthritis, get treated with medications that are not supposed to work, so they don't work. And you will see that in the practice. So immunopathogenically, we don't know exactly why this condition happens, as in so many rheumatic diseases, but there is interplay between genetic and environmental factors. Among the genetics, HLA-B27 is the strongest association with the axial spondyloarthritis. Now, how HLA-B27 contributes to the pathogenesis of ankylosing spondylitis or axial spondyloarthritis, we do not know. There are several theories, and so there are three theories that are predominantly talked about. One is arthritogenic peptide theory, where the MHC, HLA-B27, MHC1 molecule, that is, will present the arthritogenic peptide, molecular mimicry in other words, to the CD8 T cells. The second hypothesis is the NK cells will sense the homodimers of HLA-B27 on the cell surface. The third is the HLA-B27 molecules in these patients are inherently unstable. So they dimerize, heteromerize, and that leads to endoplasmic reticulum stress. Either of these three processes will then lead to secretion of interleukin-23 by those cells. And interleukin-23, when it tickles the receptors on the immune cells, then those cells will secrete. That's typically Th17 pathway, interleukin-17, interleukin-22, and TNF-alpha. And this information we use day in, day out for the treatment. And that's how we are improving with the rheumatic disease management. We are understanding more about the immunopathogenesis, coming up with new biological DMARDs as well as synthetic molecules. So that's the genetic factor. Among the environmental factors, there are two main players here. One is altered gut microbiome, and second is the trauma at enthesial sites. So gut microbial disturbances are known in patients with spondyloarthritis. And what happens is their macrophages or dendritic cells, which are surveilling the mucosa, they pick up the bacterial or abnormal bacterial products or antigens, and they present them to the Th17 helper T cells. The Th17 helper T cells then will secrete the interleukin-23, and this interleukin-23 will then downstream lead to increased secretion of IL-17. Interleukin-23 T cells will then stimulate the Th17, cause differentiation and development of Th17 type of cells, which include Th17 cell itself, interleukin, innate lymphoid cell 3, gamma delta T cells, and these are IL-23 dependent sources of IL-17. There are several IL-23 independent sources of IL-17, but IL-17 is an important cytokine along with the TNF-alpha in patients with axial spondyloarthritis. The third one that we don't use is interleukin 22. The interleukin 22 leads to osteoproliferation. So theoretically, blocking IL-22 may help with the inflammation, but as of now, there is no development there. Okay. The third one is enthesial trauma. So patients who are blue-collar workers, construction workers, farmers, they get repetitive trauma at their entheses like Achilles, plantar fascia, elbows, shoulders, and this leads to prostaglandin E2 secretion. And prostaglandin E2 is important in inflammatory cascade, where it will lead to stimulation of the enthesial myeloid cells, which will then secrete interleukin 23 and then the downstream results. When the interleukin 23 stimulates the receptor on the cells, there is phosphorylation of the JAK enzyme that causes activation and phosphorylation of the STAT, which is a transcription factor, then which goes into the nucleus and start the protein synthesis, and cytokine are none but the proteins that cause inflammation. So we have been using all this information at a very granular level by producing molecules that can block JAK and STAT, that's JAK inhibitors, molecules that can block IL-17 pathway, that's ixekizumab, secukinumab, or bimekizumab, or brodalumab for that matter. Is ixekizumab available here? And secukinumab too. Bimekizumab also. The bimekizumab is IL-17A and F inhibitor as compared to secukinumab or ixekizumab, which is only IL-17A inhibitor. So technically, bimekizumab may be more potent, so associated with higher incidence of candida infection. So how do we diagnose axial spondyloarthritis? There's no one test here. At this time, less ideal it is, but the gold standard for diagnosis of axial spondyloarthritis is clinician's judgment. So a clinician has to really go through all this, get history of inflammatory back pain, ask about NSAID response, ask about family history, extra-articular manifestations, do physical examination to look for arthritis, enthesitis, send patients to ophthalmology or GI to look for uveitis, etc. Get B27, get CRP. ESR is not as helpful in spondyloarthritis patients in my opinion. So I don't really do ESR, I only do CRP. And then you order X-ray of the pelvis AP view. You can also order concomitant Ferguson view if your radiology center does it. These are the two views that you are going to do to look for sacroiliitis. And sacroiliitis, again, it's a very difficult diagnosis to make for even an expert radiologist. So while grade 3 and grade 4 modified New York staging is very easy to identify, grade 1 and grade 2 is not as. So grade 2 unilateral or grade 3 unilateral or grade 2 bilateral is ankylosing spondylitis. But in clinical practice, what is relevant is you make a diagnosis of axial spondyloarthritis rather than trying to cleave it between non-radiographic or radiographic disease, because the treatment, before treatment, the symptom burden is similar as I showed you, and the response to the treatment is similar. You are going to treat both the groups equally intensely. So there's no point in trying to cleave unless you're doing a clinical trial or clinical research study. And MRI is very helpful. It has revolutionized this field. MRI of the pelvis, you do not need contrast. MRI of the pelvis without contrast is enough to look for sacroiliitis. And why? Because you would do contrast to look for synovitis. Here you are looking for osteitis or enthesitis. So you do not need contrast. And thorough history is the really main thing to get to the diagnosis of axial spondyloarthritis. Really need to ask about different features of inflammatory back pain. So among all comers with chronic back pain, the probability of axial spondyloarthritis is 5%. If their back pain is suggestive of inflammatory back pain, then this probability goes up to 15%. And if they have one or more of the spondyloarthritis features, then this probability may go up to 70%. And if the same patient has positive HLA-B27, then you got it. That's the diagnosis. So even if their X-ray does not show the sacroiliitis, if their MRI is normal of the sacroiliac joint, you have not really screened their cervical spine, thoracic spine, lumbar spine. And sometimes bone marrow edema can be intermittent. And it is not practical or feasible to do the whole spine MRI, at least in our health care structure. So we end up treating these patients as if they have axial spondyloarthritis. And several of these patients respond beautifully. And thank you for what you have done, because they have been going around several different specialists, chiropractors, physiotherapists, spine surgeons, getting different types of injections, unnecessary surgeries, and that this diagnosis has been elusive. So thorough history taking, there's no shortcut. And that's what I have realized in my 10 years of practice, is the most important clincher of the diagnosis in rheumatology is history taking. The tests are tests. There are two sets of classification criteria: modified criteria, which was introduced in 1984, that's for ankylosing spondylitis, and ASAS criteria that was introduced in 2009 for axial spondyloarthritis, with the motive of being able to include the patients with early stage. But these are classification criteria. SLIC is the classification criteria. Rheumatoid arthritis, ACR criteria is classification criteria. You're not supposed to use classification criteria to diagnose patients. And we tell this to our fellows and residents, and still they present cases, the patient satisfies the criteria, so the diagnosis is there, which is not supposed to be done. I already told you the 20% patients in general population have chronic back pain. About 5% of them have inflammatory back pain. If you look at the prevalence of axial spondyloarthritis in the United States is 1.4%. This comes from a 2013 general population survey data. And 0.5% or 1 in 200 individuals have ankylosing spondylitis. But if you all imagine your day-to-day clinical practice, how many patients do you see with RA or lupus versus one patient with ankylosing spondylitis? So this is very much underdiagnosed condition across the globe, and much work needs to be done. Other thing that we realized is we used to think that a patient enters non-radiographic stage, and about 20% of them within the next 2 years will develop ankylosing spondylitis, such that everybody who starts as non-radiographic disease will eventually develop ankylosing spondylitis. And that's not the case. That now we know that patients may develop inflammatory back pain. Some of them develop non-radiographic axial SPA. Some of them spontaneously remit. Patients may remain in this particular stage and will never develop ankylosing spondylitis. Even those who have sacroiliitis, not everybody is going to have bamboo spine. And when patients come to you, they read online and then they are worried about fusing their spine, fusing their joints. And this information is very important, that not everybody is really going to fuse, especially women, non-smokers, people with normal CRP, people with normal MRI at the beginning. They are not likely to be fusing as compared to the other group. After 2010, we have done much better when it comes to picking up the non-radiographic axial spondyloarthritis. Sometimes overdiagnosis has been a challenge, but we think by year 2040, we will be able to diagnose much more population at non-radiographic stage as compared to ankylosing spondylitis stage. So rheumatoid arthritis prevalence in the United States is 0.6%, and axial spondyloarthritis is 1.4%. So rheumatoid arthritis is less common than axial spondyloarthritis. Where are these patients? Because we see like 15 patients with RA and then 1 patient with ankylosing spondylitis. So this has been the focus of our research program. I founded Yale Spondyloarthritis Program in 2019, and we do several clinical and translational research studies with the primary goal of improving the diagnosis early, improving the diagnostic delay. So current diagnostic delay is anywhere between 6 to 14 years, typically 8 to 11 years after the symptom onset. There's no other rheumatic condition with this diagnostic delay. So we have several studies that we are doing, and I'll be able to tell you about a couple of them. And our goal is to find these patients early, because now we have several effective treatments and we can make a huge difference. I think we should take a look at the time. Are we okay? All right. So we want to treat them early. So early axial spondyloarthritis, the definition is coming along. I think some of you may be aware. They're saying about 2 years. Yeah, 2 years. Right. So early AS is 5 years, but for axial spondyloarthritis, and then ASAS has come up with something quite tight. They're saying if you suspect the axial spondyloarthritis, patient should be able to see the clinician within 2 weeks. 2 weeks. So my current new patient appointment is in 7 months. So it's just not possible nonetheless. So why do we want to diagnose early? Because these are young patients, and they're losing their productive career, as well as leading to poor quality of life. We do have several therapeutic agents now in each class. We have 5 TNF inhibitors, we have 3 interleukin-17 inhibitors, we have 2 JAK inhibitors. TNF inhibitors, as well as all these medications, improve the symptoms, function, as well as, importantly, may reduce the radiographic progression and prevent fusion. So it's important to diagnose them early before they have fused or before they have developed syndesmophytes. And clearly, it has been shown that early treatment is associated with better response, as in patients with rheumatoid arthritis. I have seen several patients who have undergone surgeries, and the diagnosis of or reason for their back pain was not the disc disease that somebody found. If I do my MRI tomorrow, I'm going to have some disc bulge here and there. So that may not be the reason for the pain. Also, in US, when we order MRI of the lumbar spine, that does not include the sacroiliac joints. So many times we miss the diagnosis because of that. How is it here? Same. So if they, whoever makes these protocols, if they can include SI joints in the lumbar spine MRI, we will be able to catch more patients and earlier. So since my fellowship days, I trained with Dr. Atul Devdar, Jim Rosenbaum. These are spondyloarthritis experts, and I used to think about like how can we really improve the diagnostic delay, diagnose them earlier. So we did a systematic review, and we found that there are several researchers who have created some kind of a filter. So young patient less than 45 and plantar fasciitis, or 3 of the 5 spondyloarthritis features. You use any filter and then do a research study and see consecutive patients who are fulfilling this filter. About 30 to 40% of them turn out to have spondyloarthritis. So you can use any filter for that matter. And all these studies have been positive. And then with that, the most talked about referral strategy or proposed referral strategy in the European countries, they have nationalized healthcare, so they can use this. They can implement it better than US or even in India, because it's very scattered and heterogeneous in US as well as in India. But Canada, England, Sweden, they have only one national healthcare, one computer system, so they can do this in a better way. Nonetheless, the most recommended strategy is if the patient has chronic back pain, and that started before age of 45, if they have one of the 3, inflammatory back pain or MRI or X-ray sacroiliitis or positive HLA-B27, please refer them to rheumatologist. And when this has been studied, about 35 to 45% patients have axial spondyloarthritis. But here the problem is there is X-ray or MRI and there is HLA-B27. A huge number of people walking on the street have back pain. You cannot really do B27, and doing MRI is not feasible. It's very expensive. Doing X-ray also is challenging. So how do you really tackle this problem? What we did is we did a prospective research study called Finding Axial Spondyloarthritis, and we designed a screening tool. We call that a tool. I think you guys may realize why it's called a tool. There is that's my mentor, Atul Devdar. So I wanted to name it after him. We do have this in our culture. We do have this strong Guru Shishya Parampara, no matter where you are in the world, right? And I think for a rheumatology researcher or any researcher, you need a good mentor. It's very difficult to do research without having a mentor, and I'm fortunate to have very good mentors in my career. So in the A tool, we have 3 pre-screen questions and we have 8 screening questions. I won't bore you with the details, but patient has to pass pre-screen. If they fail pre-screen, they're kicked out. If they pass the pre-screen, they are given the screener, and they have to have 3 yeses out of the 8 in the screening tool. So number 3 came after extensive literature review, and it turned out to be actually the right number 3. How we distributed this was also interesting. We created this online questionnaire. We disseminated or distributed this online questionnaire using our electronic medical record patient portals. I think you guys are aware that EMR comes with, like, they can email you, they can tell you about symptoms, request for refills or appointment, etc. And you can write to them. reply to them. So we use that patient portal as one way of getting patients. And the second one was Facebook. And we use Facebook, you can geographically direct the campaign to your county or your zip code or your area or city or town or state. So we use Facebook and the patient portal to distribute the A tool, and patients who had positive A tool were seen by me and one of my colleagues in the office. And we did their physical examination, CRP, B27, X-ray, MRI. These are the funded studies, so we could do everything for everyone. And the diagnosis was clinical. So more than 1,200 patients took the survey, and we found positive A tool in 500 of them. We could enroll only 100 patients because the funding was for 100 patients. And we diagnosed axial spondyloarthritis among 29. So out of 100, I think 14 did not complete the whole labs or X-ray or something. So we had only 86 patients who had completers. Among the 86, 29 have the condition. So like about 90-30. So 33% patients have axial spondyloarthritis, similar to the other filters. But the beauty of the filters that we prepared, there is no blood test, there is no X-ray, there is no MRI. It's all simple questions. The other thing is even a lay person will be able to answer these questions as yes or no. You don't have to get a doctor administering the tool. So in US healthcare, the responsibility of patient's care is in family medicine or general medicine or internal medicine. We call them primary care providers. And they have to take care of everything: diabetes, hypertension, prostate, hyperlipidemia, heart disease, so much. They don't have enough time to administer any screening tool, go through the history, go to the family history and do all this. So this tool can be used by all comers, lay people. You don't need a doctor. More so, young population is always on the social media. They are so much tech savvy. And the second thing, a second thought about this is patients are always the best advocates for themselves. The doctor has 100 patients, but patient has only his or her health. So we propose that this particular tool, if used as online questionnaire, will be very helpful. As other studies, when you calculate the predictive values of any feature diagnostic test, you come across sensitivity, specificity, positive predictive value, negative predictive value, positive likelihood ratio. For a screening test, positive likelihood ratio is very important. And for a good test, for example, CRP, the positive likelihood of CRP for infectious process is more than 5. 5 should be the positive likelihood ratio for any screening test to be good. Look at positive likelihood ratio of all these features is so poor. So that tells you that you cannot use one or two features. You have to use combination of features. And we did sub-analysis of this. We found that 3 is a sweet spot. And this will be also seen in the other project that we have undertaken. The AUC was also showing moderate effect. The other project that I was part of as part of Spartan is Spartan Referral Recommendation Project. The main question was which back pain patients in United States or in Canada or anywhere should be referred to rheumatology to rule out axial spondyloarthritis. You cannot really see all the back pain patients. So we wanted to create a filter that would be endorsed by an organization as compared to the tool that we created at Yale, which will be an individual effort. So we wanted to have an effort at nationwide level. So I was part of this project. And we, as any guidelines, if you are part of a guideline panel, you will see that you have to formulate PICO questions, then you have to do systematic literature review around the items that you're interested in. Then if this is a rare condition, if it is diabetes, it's easy, you have numbers there. If it is a rheumatic condition or a neurological condition, then you have to involve the experts and you have to do Delphi exercise to achieve the consensus. Among the consensus, and then that's like the expert recommendation. Nowadays, we want evidence-based medicine. We don't want eminence-based medicine. So how do you quantify the eminence? How do you quantify the expertise? Is by using some sophisticated techniques called discrete choice experiment. So we did all this and we recently drafted Spartan referral recommendations. And we wanted to create a simple checklist, less than 10 items, because there are 20, if you look at how many features you need to evaluate in a patient with spondyloarthritis, is 28. So we wanted to have a very simple, practical referral strategy. Again, we do have several features and their likelihood ratios. And if you look from the bottom row, forget about family history because the numbers were not enough, but sacroiliitis is most important, followed by family history. We did have very few studies, so I would not get stuck with this. Positive B27. So always whenever there is objectivity, abnormal X-ray, abnormal MRI, elevated CRP, positive HLB27, the positive likelihood ratios are high. So we used this information to create a scoring system. And this is the final referral tool, a referral strategy. This is Spartan referral strategy for referring patients with axial spondyloarthritis. And I was fortunate to have a PI or principal investigator role in this nationwide effort. And you will be able to soon see the manuscript in publication. So what we say is any patient with chronic, that's more than 3 months, back, buttock, hip pain that started before age of 45. And if they have more than 3 score, and there are several items, and you can create, do you guys use CHADS too for atrial fibrillation or ASCVD, this score for heart disease? Similarly, you just put it in the online computer and then it will give you a score. So we plan to disseminate this, but still it does have B27, X-ray, MRI, etc. So I have slight hesitation about how this will pan out, because then you need a middleman, like you need a primary care doctor or an orthopedic surgeon, and how willing they will be to go through all this is another question. Do you identify some of the people here? Three of them. I don't see one of the friends. Yeah, that's right. It was early morning in Washington, D.C., just in November. And oh yeah, that's right. That's right. So the middle physician is Dr. Sonam Kivalkar. She's from Pune. She studied in one of the medical schools in Pune, and she did her rheumatology fellowship in Oregon too. And I think you know Dr. Fatak. I get to see him from ACR to ACR. And I got to see Sandeep this time. I was hoping he would be here.
Yes.
I see. Yes. Okay, so that was the clinical part. I had told Varsha that each of this topic can be a lecture in itself. So radiographic progression can be a lecture, and the clinical diagnosis can be a lecture, and then the bridging the gap could be a lecture. And so I'm sorry if I have gone over the time. Depending on how much energy you guys have, I can keep going or wait here or cut it short, whatever you feel. Like, I don't know what your timeline is.
We have adequate time.
Sure. Sure. Okay. Okay.
They have boundless energies.
When it comes to axial spondyloarthritis or gout, I have boundless energy too. These are the topics that I really, and the reason is similar. There is unmet needs for axial spondyloarthritis. It's way out there in the population, but not being caught. And gout is one of the happy condition. You can fix the gout. And these patients are so happy after you bring down their uric acid level and they don't have any more flares. And then you can discharge them to their primary or family doctors. But the gout is so commonly mismanaged by everyone, including cardiologists and nephrologists. And so when it comes to gout or axial spondyloarthritis, I can keep on. Goals for managing axial spondyloarthritis is you want to reduce the symptoms, you want to maintain the posture and flexibility, reduce the functional limitations. Very important, you want to maintain their ability to work, as well as in Europe, they care a lot about this societal participation. You might have seen so many of their guidelines will say this overarching goal is societal participation. And I initially thought this is just a play of words and this does not count. But after you practice for 10, 15 years, you see like this is important. If a person who was very good runner, now they cannot even jog or go to some like friend groups and do some biking together, it affects them. I have a patient, a very nice lady who was very good tennis player. And in her late 50s, I found that she had ankylosing spondylitis. And her goal was to go back to tennis. And we tried hard and she was able to play for a few years, but then her disease did not let her do that. But societal participation is quite important. And people in India may not realize it because we do have such a robust community around us. But in Western countries, it may not be that. So pharmacotherapy for axial spondyloarthritis has evolved tremendously in the last 10 years. Until year 1997, we only had NSAIDs. That's it. You diagnose somebody with ankylosing spondylitis, you try sulfasalazine, methotrexate, NSAIDs, but we didn't. Then the TNF inhibitors came. Subsequently, from etanercept, infliximab, adalimumab, certolizumab, golimumab, all of them have been approved by FDA. Then in 2016, we got secukinumab and exicuzumab. Just recently, in like last 6 months, we got bimekizumab. And JAK inhibitors, there are two of them, tofacitinib and upadacitinib. Both have been approved for both non-radiographic as well as radiographic axial spondyloarthritis. But as opposed to the rheumatoid arthritis patients or lupus patients, the physical therapy or regular stretching exercises is as important as the pharmacotherapy in patients with spondyloarthritis. So it's very important that you tell them to undergo a structured, supervised physical therapy and then continue these exercises at home. There are several studies that have proven the role of physical therapy beyond any doubt. The combined inpatient therapy that we are not in a position in United States, so no insurance will cover this type of therapy. But in Europe, I think they do inpatient physical therapy for 2 weeks and then the supervised physical therapy. So beyond doubt, we know that physical therapy, regular stretching exercises, in other words, yoga or Tai Chi, are very important, but less than 50% patients are compliant. So whenever it comes to lifestyle modification, patients are hesitant as in any other condition. And it's not only that you see symptomatic relief or patient-reported outcomes improve. If you measure their calprotectin or pro-inflammatory cytokines before and after intense exercise program, the cytokine levels go down. So this is proven beyond doubt that regular exercises are important. And the one question I always get is, so how do you say that construction workers and farmers who are hardworking, then they get more osteoproliferation or they develop syndesmophytes more? And the answer lies, there has to be a balance. If you do too much, then it's not good. But some kind of regular exercise, like say 30 minutes, 5 days out of 1 week is important. So to summarize the pharmacotherapy for someone who already has been diagnosed with axial spondyloarthritis, you are going to avoid steroids because they don't work, especially for axial manifestations. They may work only for short duration, but you have to use high doses of steroids. It's not advisable because these patients are at high risk of osteoporosis too. So avoid steroids. The first line is NSAIDs and physical therapy. If patients are intolerant to NSAIDs or they get some side effect or they don't respond as well, so before you say they don't respond, you have to use two NSAIDs over 2 to 4 weeks time before you give it up. And you get several questions from the patients. Nahi ani ulcer hoto, mala sangitle gheu naka. So because NSAIDs in general for other conditions may not be as recommended to be taken on continuous basis. But for axial spondyloarthritis, it's a different ball game. So and then you have to take time to explain that patient that this is disease modifying drug. It's just not for your symptoms. A painkiller nahi hai. This is going to retard the radiographic progression. This may even reduce the risk of heart disease. In all conditions, NSAIDs may actually increase the risk of heart disease, but here some soft data suggests that actually because of reduction of inflammation, there may be reduction in the risk of heart disease. So if patients fail NSAIDs, then the second line is either TNF inhibitors or IL-17 inhibitors. And those who have IBD or uveitis should get TNF blockers, and that to be monoclonal antibody. All the 4 except for etanercept. Etanercept is soluble receptor blocker. The third line is JAK inhibitors, and this data mainly comes from the recent news about black box warning given by FDA to JAK inhibitors that they can increase the risk of heart disease, blood clot, cancer, etc. So at this time, FDA would like us to use the TNF inhibitors before we go to JAKs. That's in the nutshell, the algorithm. But why NSAIDs are so effective in axial spondyloarthritis? That would be a question that anybody would ask, right? So NSAIDs inhibit COX-1 as well as COX-2, cyclooxygenase 1, cyclooxygenase 2. And PGE2 is involved in regulation of various inflammatory processes as well as bone metabolism. And NSAIDs preferentially inhibit inflammation-induced COX. So whenever there is inflammation, NSAIDs work more predominantly there. COX-2 is important for mesenchymal cells to differentiate into osteoblasts during fracture healing. So sometimes orthopedic surgeons would tell patients not to take NSAIDs around the time of hip replacement or like fracture after fracture ORIF, open reduction internal fixation type of procedures. And high doses of COX-2 blockers decrease the osteogenic potential of the mesenchymic stem cells in presence of inflammation. In other words, what I'm telling you is COX-2 inhibitors may retard the radiographic progression. And so both ways, PGE2 is required for inflammation and bone metabolism. And by blocking this, you are not only improving the inflammation, but you may be reducing the bone osteoproliferation in patients with axial spondyloarthritis. And this has been proven with several studies, including Cochrane review of 39 studies that included about 29 randomized control studies. So the role of NSAIDs in axial spondyloarthritis has been proven beyond doubt. So that's why it should be the first line, unless there is a clear contraindication. Now, the next question patient will ask is, well, do I need those biologics, or I can get better only with this? And we do have one large cross-sectional study done in Germany with more than 1,000 patients, and 80% of them were on regular NSAIDs, and mainly diclofenac, naproxen, indomethacin. So about 55% patients have good response. 20% of them have complete response. 35% have at least half response. There you go. 55% of them may not need anything else. If you use the NSAIDs optimally, like not give only ibuprofen 200 milligrams 3 times dose. You want to give at least 600 or 800 milligrams 3 times a day. And if you want to make it easier, you give them meloxicam 15 milligrams a day, or Celebrex, celecoxib 100 milligrams twice a day. That's where you give that. Those are the optimal doses. If you give them the regular continuous based NSAIDs, so many patients get better. I do have several patients only on NSAIDs. I have 82-year-old people on indomethacin regularly for 40 years. And they continue, and I understand and they understand, even if their family members and their cardiologist does not understand. So we continue, right? So NSAIDs improve spinal pain, enthesitis, arthritis, as well as uveitis. That's important to know. And various NSAIDs are equally effective. There is no one NSAID better than the other. But when you switch the NSAIDs have different chemical classes, right? You have propionic acid, acetic acid, enolic acid. When you switch, say, from naproxen, do not switch to ibuprofen because it's the same chemical class. Use indomethacin or diclofenac or meloxicam. I like meloxicam for the once a day regular use. I used to use etoricoxib when I was here. I don't think we use as much there. Yeah, right. All right, 25% patients don't tolerate NSAIDs, so you have to use something else. And there are two studies, one using celecoxib, where they found that continuous use of celecoxib reduced the radiographic progression in ankylosing spondylitis. But then the latest study was done using diclofenac, and the data showed that there was no benefit of continuous diclofenac use as compared to placebo to reduce the radiographic progression. So the thought is maybe COX-2 inhibitors are more selective. So Celebrex is more likely to reduce the radiographic progression than the non-selective NSAIDs. What's the role of conventional synthetic DMARDs that we have plentifully available everywhere, right? Methotrexate, azathioprine, sulfasalazine. And when it comes to axial involvement, the methotrexate nor sulfasalazine has been proven. So patients with axial involvement after NSAIDs, the option for them is biologics or the small molecules, JAK inhibitors. Although I have heard from several physicians outside the United States that they use sulfasalazine, it tends to help. And this may be different, genetics, different environmental factors. I do have a friend of my friend in Chicago who I suggested using sulfasalazine for sacroiliitis. Worked.
Microbiome theory that they say because it works on the gut.
Right.
To introduce the microbiome.
Right.
So that is
right. Right. And I think there's truth in it. So right. Yeah, that's right. Yes, yes. So sulfasalazine, I think it's a relatively benign and safe drug. If a patient is not able to afford or does not want to take the risk of taking biologics, I think it is fair trial to give sulfasalazine at least 1 gram twice a day for 3 months and see if they feel better. You can continue. If they don't, then you have to take the next step. The evidence favors sulfasalazine over methotrexate, even for peripheral inflammatory arthritis in patients with spondyloarthritis. And the last thing is when we used to use infliximab, we used to use methotrexate to reduce the formation of anti-drug antibodies. The data is on both sides. So last ACR Spartan guidelines do not recommend that you have to give methotrexate in addition to TNF inhibitor to potentiate or to increase the retention of the drug. So we typically don't use that unless somebody goes on infliximab when it becomes more clear. So TNF inhibitors in axial spondyloarthritis, the most commonly used drug class even now. The first drug to give after NSAID failure is TNF blockers. You know, TNF is pleiotropic cytokine, it's pro-inflammatory, etc., etc. But there is direct information when there is a very couple of small studies. They did SI joint biopsies and looked at the TNF expression, and there is plenty of TNF expression, mRNA expression there in the SI joint. So that's how I think this all came about. There has been use of intra-articular TNF inhibitors for several rheumatic conditions that never panned out. Now, how good TNF inhibitors are in patients with axial spondyloarthritis or ankylosing spondylitis, and is there one TNF inhibitor better than other? That's the question we get all the time, because insurance companies may allow you both the infusions as a self-injections, and the patients say, doc, which medicine should I go? Tell me. And you tell them, like, it all depends on your convenience. Do you want to come to our infusion center a couple of months, or you can do it self-injection? It's pen, it's easy. And so bottom line, the response that we measure is by ASAS 20. So it's like in rheumatoid arthritis, you have ACR 20, ACR 50, ACR 70 criteria. In axial spondyloarthritis, we have ASAS 20, ASAS 40. The previous studies used to have ASAS 20 as their primary objective, but the more recent studies, ASAS 20 is like, so you are saying 20% response. We used to celebrate success with patients getting 20% better. And then patient says, I don't want to get 20% better. I want to get 100% better. So we are doing, but anyways, with the combination therapies, I think we will do better than what we are doing. All the NSAIDs are equally effective. All the TNF inhibitors are equally effective. The ASAS 20 response is comparable. There is no head-to-head study, but when you look at their ASAS 40 response, even that is comparable. All the TNF blockers, their ASAS 4, so 40% improvement is also. So in other words, about 40 to 50% patients, when they get TNF inhibitors, they get at least 50% better. Make sense? Okay. Same for ankylosing spondylitis and non-radiographic axial spondyloarthritis. Although only TNF inhibitor that was formally studied in non-radiographic axial spondyloarthritis is certolizumab, which is a large pegylated molecule that you will prefer when a woman in child rearing age comes and they need to be on TNF blockers. You are going to use certolizumab. TNF blockers improve almost all extraarticular manifestations, axial manifestations, peripheral manifestations. I think there's no risk. Like if you use IL-17 inhibitors, you are risking whether patient will develop IBD or their uveitis does not get treated. JAK inhibitors, as I told you, is black box warning. TNF blockers treat all, right? Is switching TNF inhibitors a viable strategy? Like if a patient did not respond to TNF blocker, can you try another TNF blocker? And the answer is yes. So there are two types of non-responses: primary non-response and secondary non-response. Primary non-response is where patients from the get-go did not respond. So there is less data about the primary non-response patients, but secondary non-response is when patients get on one, they get better, but after 6 to 8 months, maybe 1.5 years, they say, now it's not as helpful. Do you change the class? Or you change another TNF do you change to another TNF blocker? And what you do is you change to another TNF blocker because you want to conserve the drug. Although we say we have several options, we have only 3 classes. So you don't want to exhaust the options. So that's why the treat to target strategy that the European groups recommend. They want to use something like gout or what else? Diabetes. You use treat to target strategy. You want to have A1C below 6.5 or gout uric acid below 6. That is not going to work in axial spondyloarthritis because you don't have a good target. And that target is so woolly, like cloudy. You don't have a test. It's all patient-reported outcomes. How much can you rely on it? So you don't want to cycle the patient through different biologics and exhaust all your options. So several trials for IL-17A inhibitors as well as IL-17A and F inhibitors. And again, same story. All the three IL-17 inhibitors are equally effective when you look at their ASAS-20 response or ASAS-40 response. So you can pick whatever IL-17 inhibitor is available in your area and whichever is approved by their insurance company. More important in our area, the insurance companies play a major role in which biologic the patients can get because they have only one for their formulary. Yeah. Same for IL-17 inhibitors in non-radiographic axial spondyloarthritis. So nowadays, the habit is do randomized clinical trial, one for AS patients, the other for non-radiographic patients, get approval by FDA for both. So this is what the pharma companies have been doing. And IL-17 inhibitors have been effective in both non-radiographic axial spondyloarthritis. Same for ASAS-40. Similarly, so what I'm trying to tell you is no one IL-17 inhibitor is better than the other. You can use either of them. They improve the...
Switching to IL-17.
I prefer to do two TNF inhibitors before I go to IL-17. I usually do not go to third TNF inhibitor because it doesn't really make sense. Yeah. Another thing that we do is there are several patients who are morbidly obese. And when you use self-injections in them, you can give only some fixed dose. So if you use infusions, then you can give weight-based. And now we have infusions of infliximab, golimumab, secukinumab. So when there's somebody who's morbidly obese, I prefer the infusions over at least the second TNF before, calling it a day. Use infusions before going there.
Pregnancy, which one? We don't have certain. We don't have certain.
So TNF inhibitor wise, I think you could like Enbrel and etanercept and Humira, you could continue. And just before, like in the third trimester, you can hold. Yeah, because organogenesis actually starts at the late first trimester. So there are very nice ACR guidelines. I'm sure you know. Very, very practical. So you, Dr. Krishna, you may know, previous ACR guidelines would be, you can do this also, that also, and it was all, like you just don't read the guidelines because you can do whatever you want. That's how the rheumat. Diagnose however you want, do whatever you want. This is basically what ACR guidelines, and we used to laugh about like, what do you guys do? You meet every 3 months and come up with some guidelines which are not useful. But now they are coming up with very crystal clear things that you can really follow. So who is that? Lisa Samaratino is one of the rheumatologists. She's at Hospital for Special Surgery. She's very interested in the pregnancy outcomes and rheumatological conditions. So she's the first author, I think, or senior author. Those guidelines are the best so far when it comes to pregnancy and rheumatic medications. I encourage all of you to print out and read those guidelines. They're beautifully written, very nicely written, as well as very useful. Because so many patients in rheumatology clinics are women. It's good that we know those guidelines well. So IL-17 inhibitors, the main problem, I won't go through all the points. The main problem is exacerbation of underlying IBD or creation of de novo IBD. So if somebody has history of IBD or active IBD, you're not going to use IL-17 inhibitors. Even when somebody has family history of IBD, then you are going to closely watch them. The second thing is they can get candida infection, fungal infections more often, but typically they're non-serious. But IL-17 inhibitors, and then the third thing is predominant psoriasis. If a patient with axial psoriatic arthritis has resistant or widespread psoriasis, then IL-17 inhibitors can be even chosen before you go to TNF inhibitors. JAK inhibitors, the trials have been done in AS as well as in non-radiographic axial spondyloarthritis. Again, we have similar story. The ASAS-40 responses, now so we have gotten better. Now we don't have ASAS-20 anymore. The primary outcome is ASAS-40. And both the tofacitinib and upadacitinib work very well. Depends on what you have available. And then JAK inhibitors are pan blockers. They are new prednisone. They work for almost every condition: RA, lupus, vasculitis, spondyloarthritis, you name it, sarcoidosis, myositis. So they are new prednisone because they are pan blockers. So that therefore JAK inhibitors are quite effective. And I heard that they are not as expensive in other countries.
Mainly the problem is the cost. TNFs are much more expensive.
Right, right. Because this is a chemical tablet. This is like easily manufactured. So JAK inhibitors are quite effective. They help with extra-articular manifestations as well as the axial and peripheral arthritis. The tofacitinib and upadacitinib have been already approved. The filgotinib, the trial was halted because of some risk-benefit profile. But in September 2021, based on the oral surveillance study that was done in patients with RA above age of 50 who each had at least one cardiovascular risk factor, the study confirmed that the JAK inhibitors indeed increase the risk of blood clot cancer and heart disease. That's why there is a black box warning. I think we are going through a phase of unknown because RA is a different disease immunopathogenically. Lupus is different disease. This spondyloarthritis is more blandish, or like it's more inflammatory than autoimmune. And the baseline risk of lymphomas or malignancies is less to begin with. These are younger patients as compared to patients with rheumatoid arthritis. So I won't be surprised if this black box warning is applicable only for RA or lupus patients and not for psoriatic arthritis or spondyloarthritis patients. But at this time, it's upon us that we have to educate our patients and tell them. And most of the patients, when you give them a drug to improve their pain, but that can kill them, they don't want it. So they are very hesitant to go on JAK inhibitors. These are all biologics for ankylosing spondylitis. The ASAS40 responses are quite comparable. In other words, you said, is secukinumab better than adalimumab to begin with? And it's not necessarily true, but these are not head-to-head studies. This is network meta-analysis type of data that's coming up. IL-23 inhibitors, because I told you so much about IL-23 that has so important role early in the pathogenesis of axial spondyloarthritis. Anybody would think that IL-23 inhibitors will be very useful, but they have failed in axial spondyloarthritis. And there are several reasons that why IL-23 inhibitors may have failed. Now, where we are going is towards combination therapy. There's a study going on, guselkumab and one of the TNF blockers, I think golimumab. So the combination therapy may tell us what really is the effect. So when you give TNF blockers or IL-17 inhibitors or NSAIDs over long period, you definitely reduce the chances of radiographic progression. The base for all this is whenever you are trying to do something to reduce inflammation, you are going to reduce the radiographic progression. And that's what we are learning. The last thing that you always get asked is, I'm doing so much better. Why can't we stop this? I don't want to take this medicine, expensive or whatever it may be. Several studies have been done, and they all tell us this. Discontinuation of biologic demand leads to disease flare in majority of the patients. So stopping is not a good idea. Slowing is good. So you can increase the interval between the doses. So I typically give them adalimumab every 4 weeks. You can do infliximab every 10 weeks. You can play around. Stopping is not a good idea. Reducing the dose may be an option. This is another important thing. Like you sometimes or many times I get these patients who have not responded to any therapy. And there first thing that you do is any rheumatologist does is question the diagnosis. So you get a patient who was managed by another rheumatologist. The first thing that you will question the diagnosis, like, is it the real diagnosis? You're not going to take the word for another rheumatologist, right? This is how we are. That's our nature. So your first thing is you question the diagnosis, even if it is your own diagnosis. The second is you find out if the disease is active or like, what am I treating? Am I treating damage or the disease? So you can do CRP, MRI of the spine, MRI of the SI joints. But if this is osteoarthritis that has developed because of chronic inflammation, you're not going to do anything by changing the biology. The next one is the patient compliant with the treatment? Other thing is in axial spondyloarthritis, there are several other things play a part. Depression, fibromyalgia, 30% people have fibromyalgia. And one thing that I find more and more is sleep apnea. Because of the changes in the neck and overweight situation, sleep apnea is quite common, and every patient who has untreated sleep apnea feel tired, feel more stiff, feel more achy, nothing helps them. So I send patients who are not responding to the sleep study to look for sleep apnea. The other thing is, have I set realistic expectation? As I told you, like ASA's 40 response is about 50%. So you have to tell the patient you're not going to get like completely better. You can get as much better as possible. And it's very important to start early. If you are already seeing a lot of bone marrow edema on MRI and they have failed NSAID, and patients always say like, I will think about this, I will come back later. And then you lose the time. So earlier, starting the treatment earlier is important. The other thing is, should I try SI joint steroid injections or send them to pain clinic for nerve ablation? Intravenous pamidronate. This is what I did when I was in my post-graduation in Mumbai. We had only NSAIDs, sulfasalazine, and the next thing was IV pamidronate. So we used to admit them for IV pamidronate.
Thalidomide also used to.
Is it? Yeah, I did not, but yes, yeah. So Dr. Shashank Akerkar was my lecturer. We used to admit so many patients for IV pamidronate. So I was the pamidronate champion then. You can maximize NSAIDs, you can cycle through NSAIDs, you can add the biologic and NSAIDs together. At this time, there's no approved combination, but we may come up with the combination biologics that GI doctors are at the forefront of this. They are a little bit more bolder. They combine biologics all the time for the Crohn's disease. And they're finding luck without really necessarily increasing the side effect profile. So we'll learn more.
Which ones do you combine?
I have not combined as much in axial spondyloarthritis, but psoriatic arthritis, Enbrel and apremilast commonly. IL-23 inhibitors, anti-TNF blockers commonly. And then you have to be creative here, because if you are the one who's writing 2 prescriptions, the insurance company will reject one of them. Because you are using 2 medicines, you need to use one. So you tell the dermatologist to give one, you give the next. Get it? You work around the system. Like there are systemic challenges everywhere.
Yeah, it is.
TNF blockers. Yes.
Any of these others are not, none of them others should be given. TNF blockers are not working, keep coming back with recurrent uveitis in spite of being on the TNFs.
So I think if you look at uveitis itself, sulfasalazine has data in uveitis. Methotrexate works in uveitis. So I would do methotrexate if the patient can take methotrexate. And the last thing is mycophenolate. Mycophenolate does work in uveitis, but I have seldom used mycophenolate in a patient with spondyloarthritis because it does not have effect on the MSK symptoms. But I would go on methotrexate or sulfasalazine. Maybe sulfasalazine because it has role in both conditions. And there is data about sulfasalazine and uveitis. All right, so last 2 slides. Conclusion, axial spondyloarthritis is the most frequent type of spondyloarthritis. Presentation is heterogeneous. You need to have high index of suspicion for diagnosis. Diagnostic delay is tremendous, and early referral is important. I think everywhere the referral system is very different. So what I would do in India or United States is educate the general practitioners who see patients, or spine surgeons who see patients, young patients with back pain, and tell them about this condition exists. It's not only listed in textbooks. That's how they look at it. Ankylosing spondylitis. They say, oh, something very rare. It's not as rare actually. So early referral is important. Disease burden is similar in early as well as late stage. And patients with non-radiographic disease respond equally well as radiographic axial spondyloarthritis. We can do a major change in the patient's lives if you catch it early. And I have experienced it myself firsthand. So that study that I did, I have a researcher from Pfizer who is with Pfizer for several years. And he came in the study, and only because of the study, he got his diagnosis. He's doing beautifully well only with Celebrex, has lost weight, living productive life. I have a welder who was not able to turn, but was being blamed on his obesity and other things for his symptoms. And only because he came through the research studies and filled out that A tool on Facebook. He had some time, and then that's how I got him. And he's a changed man today. So we can do a lot if you can diagnose these patients early. Several medications are available. Newer medications will be available because we understand the immunopathogenesis. And the place of different biologics will become more clear as we have more experience. Any inflammation in the body, we have been taught in med school, right? If there is an abscess, it has to be drained. Any inflammation in the body, we have to treat to reduce the risk of organ involvement and long-term risk of heart disease, etc. The unmet needs are new biomarkers for disease activity. We need a diagnostic biomarker, but this being an inflammatory condition, I don't see an antibody playing a role, although anti-CD64 antibodies are being studied. And then we need to know whether we should go for adalimumab or secukinumab. Unless we have a head-to-head data, it will be difficult to know. So with that, I would like to thank you. You guys have been really patient. I would like to thank my mentors. A-Tool has been very instrumental in what I could do after I went to United States. So I'm in touch. And Rick Bukala is he's my chief. And his main area of the research is macrophage inhibitory factor 1, MIF1. And in addition to that, he's working on a vaccine for malaria. So his areas are not rheumatologist. He's a rheumatologist, but his areas have changed. Linda is our associate dean. Monique is my dear colleague. She works a lot in scleroderma. She's always looking for clinical research and enrolling patients. So if you have a lot of scleroderma and you would like to if you want to do some research project in scleroderma and you have a lot of patients that you can contribute, I can get you in touch with her and she'll be happy because she's always looking for collaborating. And scleroderma being a rare disease, it's difficult to get patients. So let me know. Vaidehi Chaudhary is my clinical chief. She's a BJite. She's MBBS, MD from BJ, then DM from SGPGI, Lucknow. She has been my mentor, and Lenore Buckley is one of my clinical chiefs. And I have several team members, of which you see Deborah Desir is just outgoing ACR president. I share an office with her. So Dr. Desir and I both see our psoriatic arthritis patients in conjunction with our dermatology colleagues. And then we have MSK radiologists and bunch of fellows and research coordinators who, the research is very difficult unless you have a good team. And everything is impossible without good patients. So we always thank patients. It's a privilege to be able to give care. So thank you very much.
Thank you so much, Abhijeet.
Sure.
Such a wonderful presentation and for questions. So we have time for questions and there are a bunch of questions.
Sure.
I'll just see on the chat box also if there is anything. I go to the Zoom.
Maybe you can stop share.
Stop sharing. Okay. And just so yeah. If anybody has questions, please type them in the chat box, the Zoom attendees. We're taking Q&A now for 15 minutes. Okay.
Yeah, that's right.
Thank you, Mr. Paul, for this comprehensive talk on spondyloarthritis. So, a lot of our patients, like you also said, are young people who come in and some of them are gym goers and they have concerns regarding physical therapy. Should they be continuing lifting heavy weights? We know what exercises are good, like you said, mentioned Tai Chi, and we recommend those. But they can continue, they want to continue tennis and want to continue into contact sports and into gymming. So what would be your advice to such a patient?
I think it's fine to do the exercise at the level that they are used to. For example, if somebody is really active and they are weightlifters and they have been going to gym and they are used to doing 2 hours a day, fine. I don't think that's going to be having any deleterious effect. I can give you an example. When I was fellow, we had a patient who was on IV infliximab infusions. And because of the AS, he went for disability. and then he had all the time for himself because the government was giving him money, right? Guy who used to be in the gym at least 2-3 hours every day, and after a year or so, we were able to really delay the interval between the infliximab infusions. I have seen him, like I have seen him for those 2 years when I was there. So yes, they can continue.
Thank you, first of all, for the talk. It was very comprehensive, like a summary of all the previous studies. So what is your take on use of concomitant DMARD? Like what you mentioned, the Spartan guidelines do say that the concomitant DMARDs cannot be recommended. But if I'm not mistaken, the ASAs do still say that you have a greater chances of going into remission if you have a concomitant DMARD which is being prescribed. So which one do you suggest we use? Like if you're giving adalimumab, what about
Methotrexate with adalimumab combination.
When you look at the patients with spondyloarthritis, psoriatic arthritis, there are different domains of the condition. So it depends on what we are talking about. If we are talking about peripheral arthritis that is not responding only to adalimumab, then adding methotrexate or sulfasalazine may help, or uveitis may get better. But if you are treating their sacroiliitis or spinal inflammation by adding the methotrexate or sulfasalazine, I don't think it will pan out as well. Unless you have no other option, patient had recent cancer or some comorbid like kidney failure, they're on dialysis, you don't want to further immunosuppress them, then you could really, if in a rock and hard place, you could, but otherwise I would not.
Does adding it substantially prevent the formation of antibodies to the anti-TNF?
It's a proven fact that if you use methotrexate or sulfasalazine or azathioprine, you reduce the formation of anti-drug antibodies. But this whole field of anti-drug antibodies also is interesting because not every time these anti-drug antibodies are pathogenic. So how do you know? So we don't even check.
Yeah.
Yes. You understand? So yeah, if you want to potentiate, you could use thinking as, but the patients also don't want too many medications and you have so many other options. It all depends.
One small request, your review article in Nature on the treatment of spondyloarthritis, if you could share that with us, we'd be glad.
Sure. Yeah, I'm happy to. I'll email it to you.
Because it's not freely available and we have access for 23, so it was 22 if I'm not mistaken.
Right. Yeah, I'm happy to. There's a more recent JAMA article that Dr. Devdar has written with Mohammed.
I think the end of said Jack and MC.
Combination? It will be risky. Right. Yeah, no, I have not seen a patient being treated with this. And I think once you go to JAKs, then those may be enough by themselves.
I have a question. In India, because of the inherent cost problems, we are using JAKis first and TNFs sometimes later for many of our patients. But how would you comment on that?
Which disease?
For axial spa.
Yeah, as I like my blind belief is JAK inhibitors are not as risky in psoriatic arthritis and axial spondyloarthritis because the nature of inflammation is different. These are more innate immune system driven diseases where the baseline risk of malignancy is not as high as compared to autoimmune diseases like lupus, Sjogren's syndrome.
And even RA.
Even RA, I agree. RA, where the baseline risk of lymphomas and the risk factor for lung cancer is high. So I think.
So it's more disease driven than.
To me, it is disease driven. And I think in the next 3 to 4 years, we will realize that this is not as risky. For example, in a few years ago, febuxostat, there was a talk that febuxostat increases the risk of heart disease and death in patients with gout. And this came from one NEJM study where more than half the patients had dropped out. Then there was a study, FAST, came in Lancet, and then 3 more observational studies. And now we don't worry about febuxostat and heart disease. So this may change in few years.
Another thing is extraarticular features, mostly dactylitis, enthesitis. These are sometimes very resistant to treatment.
That's right.
So what would you do for that? Would you use a multi-pronged, like TNFIs in combination with something else, or just TNFIs will take care of that?
If you can locally give steroid injections, that can help. Physical therapy can help. TENS unit can help. And if you have to go to the medications, short courses of NSAIDs or short courses of methylprednisolone could help. And there is a new 10X. The procedure name is called 10X, TENEX. It is being done more frequently for Achilles tendinitis. So I think something I would try to give something local before adding more medications.
Some patients who come just with heel enthesitis and actually nothing else. So don't get any markers positive. We
Right.
don't get any actually we do all
Right.
of the all are negative.
Right.
So ultrasound also is not very helpful. So
Right.
you try suppression. The steroid well really could help.
I think NSAIDs are usually effective for enthesitis, but if the NSAIDs fail or patients cannot be on NSAIDs, sulfasalazine, I think I have found luck with sulfasalazine in such patients.
Is there a paucity of improvement trials in this setting as we see in other diseases? The one recent one we had is on secukinumab versus adalimumab, but we don't have any in the JAK inhibitor versus an adalimumab. Most of them are retrospective case series, or there is never a randomized control trial. Is there any reason why there hasn't been that head-on trial?
Great question. It is not much to do with science, but the study that you just said, SURPASS, it was not done to look for effectiveness. It was done to look for radiographic progression, which is such an interesting and difficult area to study. That MSAS score, if you look,
It's a very expensive score, clinically not.
no, you have to do it. You have to really do a study for 6 years to know the radiographic data, and the radiographic data is not really so. When I see a patient who has fused spine and they don't really hurt, I may not just give them biologic because of the radiographic changes. You treat the patient, not the X-ray changes. So yeah, I think, and it's maybe pharmaceutical companies don't want to invest as much because they're afraid of failing and then spending money, not getting anything out of it.
One last
Yeah.
question. The patient is on NSAIDs for this spondyloarthritis. When do you take a call on how to taper? In biologics, as you said, we can just increase the interval. After how long of an NSAID therapy? If let us say when it is effective, when do we start tapering? How do we get a need-based therapy, or do we just taper it down as the time progresses? How do we do that?
3 months. And that too is not like, it comes from how often can I see a patient. So if you are able to see a patient in 6 weeks, you could start in 6 weeks. Typically, we have 3-month intervals. So after 3 months, if they're doing well, then if they're on BID Celebrex, I would go on OD and then alternate day and then no Celebrex or on-demand Celebrex.
What is the longest you've used TNF blockers? Longest in terms of years in a patient?
If I have to recollect, 7-8 years, easy. Yeah.
So at least 2 years now. So they also thought if we treat it very early, like in the first year, or you treat it after 2 years, there's not much difference. There was some graph which I see.
Right.
At least
Right.
treat or not to treat.
Right. It's very heterogeneous. It's very difficult to put this in a box, and we will need so many patients to really come up with a solid answer. And every patient's intensity of symptoms is also different. So you don't feel like, especially for non-radiographic axial spondyloarthritis patients, in whom
Were my patients. So, they had radiographic changes, but they had very good response to NSAIDs.
right.
They went off NSAIDs after 2 months, but the radiographic spondylitis is there.
Right.
So HLA-27 positive
Right.
also. We have diagnosed it also.
Right.
So just a regular follow-up.
Yes, you continue the inserts, and if they are doing fine, so we use like active AS and stable AS, right? And these definitions also come off the clinical judgment rather than a particular number. I use BASDAI way more than the ASDAS. So BASDAI of less than 4, and they're doing well, fairly well. Continue the inserts.
Last question is, when the patients have severe neck pain, there are many people who develop neck small cell spines pretty early. They don't somehow respond well. Like the back pain goes away, and overall their mobility, but the neck pain and the mobility and the rotation remain restricted, like in spite of regular anti-TNFs.
Yeah, cervical spine disease sometimes can be challenging, and I see this more in psoriatic arthritis patients. They may not have sacroiliitis or lumbar spine involvement, but they have a lot of cervical spine involvement. And you are left with, the conventional other things. But I'm not sure if I would change from TNF inhibitor to something else only for the neck, because unless you find bone marrow edema and osteitis on MRI of the cervical spine.
They don't even dry well. That's
Yes, it's a challenge. So like diagnosing early is the best that we
The nail changes reverse reacting with IL-17,
Yes.
etc.
Beautiful. Yes.
We haven't seen that many.
Uh-huh.
We haven't given IL-17 that much.
I see. Yes. Yes. If you look at the clinical trial data, then JAK inhibitors have more. But yeah, I have seen IL-17 inhibitors responding, like nail psoriasis responding. Yes. Yes.